So thanks everybody. This is part 3 of our West Coast Fellows Conference. We've had a great experience thus far, and very excited to have Dr. Berven with us today to talk about healthcare economics. And I was hoping maybe Greg, if you could just do a brief introduction for Dr. Berven, we can get started.
Sure. Huge welcome to Sig, and thanks for taking the time out of a tremendously busy schedule. I know that. Everybody knows Sig Berven. I was thinking about that this morning. I was like, people call people prominent, and et cetera, but like Sig is really well known for multiple things. One is he gives phenomenal educational lectures and courses and teaches incessantly. But he's also known on the lighter side for he's actually a pretty incredible athlete, and he's a really big guy, but like his agility on like the slopes, or if he's on a bike, or if he's running, I mean, the guy is constantly active, and this little pearls about him is, even a guy that's as busy as Sig finds time to take care of himself, and I think for that reason, and in and of itself, is a great enough reason to have you on board with us here, Sig. And thanks for all you do. Thanks for leading the way for us and showing us a better way of life.
Hey, thanks so much for including me today. And we've got until 7 o'clock. Is that right?
Yeah.
Yep.
Terrific. Well, thank you for again inviting me to participate in this. With regard to athletics, I thought you were going to put up a picture of us ice climbing. So Greg ice climbs like a mountain goat, and I could tell you that's an athleticism that's not my thing right now. So, hey, honey, I'm having trouble sharing my screen. It says that right now, if you stop sharing, then I'll put some slides up.
Okay.
And terrific. So again, thanks for the opportunity to contribute to this West Coast Fellows Forum. And what I was going to focus on today is a bit of a case-based type of a presentation, and talking about healthcare economics, and having a case-based discussion of healthcare economics and some of the challenges that we face as stewards of spine surgery. And I think this is a really important role that we assume as we move into being surgeons, either surgeon leaders within our hospital, within our local group, within our community, within a region, or nationally. I think it's awfully important for us to practice responsible stewardship and recognize that what we do has a big impact on healthcare economics. And I'm just going to give a couple background slides, and then what I thought I'd try and focus on is a couple of cases to just demonstrate some of the disparities and some of the challenges we have in healthcare. These are my disclosures. I don't think they'll be relevant to the talk today. So as an overview, spinal disorders, and we as a community who care for patients with spinal disorders are important, and they're an important priority for our healthcare system, both in terms of the impact on patients as well as costs. And an important observation that's made is that despite the fact that we spend more in the US in healthcare than any other country in the world, we have some real deficiencies. And I would suggest that some of these deficiencies are modifiable. Disparities in care, disparities in income, and disparities in care are greater in the US than most of the industrialized world. So access to care can be a major problem. Costs of care, oftentimes we have rapid rates of rise of costs. I'll give you some examples of that. And we don't necessarily get a lot for when we're spending more. It was Thalgott who wrote that you get what you pay for. I'm sorry, it was Kurt Vonnegut who wrote, you get what you pay for. And sometimes we don't get what we pay for. We've got a large uninsured population in the US. And right now, there's more than 12% of our population that's either uninsured or underinsured. And the big trouble there is that medical bankruptcy, that's something we don't see anywhere else in the Western industrialized world, is medical bankruptcy. We've got over 600,000 people in the US that personally go bankrupt because of medical bills. It's the number one cost of personal bankruptcy in our economy. So more than people defaulted on their homes or bad investments, etc., medical bills are the number one reason for bankruptcy. When we think about complex surgery, and a lot of what you who are fellows are doing is complex surgery that's expensive, that's resource intensive, that involves a lot of implants. At the local level for our hospitals, the sustainability of doing complex surgery with Medicare reimbursement can really be a challenge, and the contribution margins simply aren't sustainable for a lot of places. Oftentimes, this is driven by how we adopt new technologies, and we adopt new technologies, new techniques, sometimes without considering the costs or cost effectiveness of what we're doing, and really trying to pay more attention, again, as stewards of new technologies, towards cost saving approaches rather than approaches that generate cost without necessarily concurrently generating value. There's a lot of complications, especially in spine surgery. If we look at deformity surgery, complication rates of 40% or more in some of the complex spine surgery. So again, as being stewards, both at the hospital level as well as the national level, recognizing what we need to do to try and avoid complications. And in many cases, this involves changing who we're operating on and making modifications of modifiable risk factors. One of the issues is who is really taking the risk, and who's taking the risk oftentimes is the patient and the hospital. And sometimes there's a disassociation between the surgeon and the patient in terms of who's actually getting the benefit and who's taking the risk. And that can create some real perversities in our system. I do think I've got some confidence that reimbursement reform and sharing risk can make a difference. So far, the evidence for bundle payments has been mixed. And ultimately, some of you know, I'm a pretty big advocate of a universal healthcare option, not necessarily a single payer system, but a universal healthcare option. And I'm not going to talk much about that today, but that's something that requires a bit longer talk. But what I'm going to show is some cases that exemplify why. So again, I want to get to cases soon, but just by way of background, what are the priorities for a healthcare system? Well, disorders that have a high prevalence, disorders that have a high impact, and spinal disorders meet that bill. So spinal disorders are a priority, and surgery for spinal disorders has risen rapidly. Right now, we're doing about 800,000 procedures, fusion procedures alone in the US. That's a 15-fold rise in the first decade of this century. And the cost burden associated with this is as high as many common other medical conditions, including cardiac disease, diabetes, and chronic medical conditions. The rates of spine surgery now are near the rates of hip and knee replacement, which historically they haven't been because they've risen so much more rapidly. We're both dealing with an aging population, but spine surgery growing disproportionately. And what's important to recognize is that the largest rate of rise has been in complex surgery, so spinal fusions, more than simple procedures. And this is a paper that Jeff Gums wrote some time ago now, a couple of years ago now, looking at 3-column osteotomies, pedicle subtraction osteotomies, and the rate of rise of complex, expensive surgery has been disproportionate. So if we look at, I started my practice in 2000, so at the beginning of the century here, and we've had nearly a doubling of the number of procedures that are done for spine surgeries just over the course of my career. And then if you look at the cost per procedure, that's gone up by another double. So suddenly this becomes a geometric rate of rise. When you look at cost per procedure and the numbers of procedures rising, then this becomes really an asymptotic geometric rate of rise. We look at cost to our healthcare system. So what do we get for what we spend? Well, there's a lot of evidence to suggest that as a nation, we're not really spending our money very effectively, or we're not very effective at providing the top quality of healthcare. I think the problems we've recognized, unsustainable rates of rise of cost, and anybody who's in a leadership position now in hospitals recognizes how problematic this is, limited access to care for our patients, and a lot of variability in care, including some quality deficiencies that are impossible to ignore. Oftentimes the inappropriate use of care, especially complex surgery. And I mentioned already the problem of personal bankruptcy, medical bills being the number one reason for personal bankruptcy. So these are real deficiencies that are unique to our healthcare system. And my my classmate from Stanford and also from med school, Atul Gawande, has written about this pretty extensively. And he talks about nonsense in spine care. And to some extent, I think the fee-for-service healthcare that we've all perhaps benefited from has really been problematic in generating costs. Reimbursement based on volume rather than value leads to an inappropriate use of care. There's a disassociation between reimbursement and the outcomes of care, so no real accountability for the outcomes of care, including complications, and the disassociation of risk. So the more costs that we generate as providers, that's not something that we actually face in terms of risk. The hospital system may face it. The patient certainly faces it. Our healthcare payers face it, but we're disassociated from that. So as decision makers, we've really got to be responsible stewards for trying to control costs, because everything we do has an impact on the total cost of care. So, and reimbursement models may change this, and this is a longer talk. But what I want to do is get into this area here. So what I did is I put together a case in each of these areas that I think sort of exemplifies some of the deficiencies and problems of our healthcare system. So problems with regard to access to care, and I'm sure all of you in your fellowship and in your training and certainly in your practices recognize some of the troubles people have with regard to accessing care, especially when they're uninsured or underinsured. I had an interesting case about COVID and our healthcare economy and how COVID has affected access to care for patients. So I put together a list of these cases, and what I thought I'd do is because we're virtual here, maybe I'll just choose a couple that we can walk through. And one of the areas that I feel pretty strongly about is access to care. And by way of background, this might be a problem. All right, I might have to open this another way. Each of these is supposed to link to a talk, and it's not. Let me try another one. So by way of background, in the US, we've got more disparity of wealth. I'm going to stop sharing my screen for a minute and see if I can pull up a couple of these cases. In the US, we've got more disparity of wealth than any other Western industrialized country. And that was written in a book some of you may know of called Capital. And the problem with their disparity of wealth has been we've also got disparity in expectations with regard to what we should be getting for our healthcare system and in access to care. If you look at what happens with the top 10% of our healthcare economy, and if you look at what happens to people in the top 10% of income, the health status of those patients, those people, in terms of life expectancy, is actually better than anywhere else in the world, including Finland and Scandinavian countries that are often lauded for their healthcare efficacy. The trouble is that because of disparities of wealth, when we look at the bottom 50% of our population, access to care is a major and a daily problem. So infant mortality rates, we rank 37th in the world in terms of infant mortality. A lot of less industrialized countries do much better than we do by that metric. Overall, life expectancy is another metric. I'm just going to keep on talking here without slides. I'm trying to pull up my cases, and somehow my link didn't work. But overall life expectancy, again, our life expectancy is significantly less than most of the Western industrialized world. When you look at our entire population, if you take out gunshot deaths and the fact that most gunshot deaths involve younger people, indeed, our life expectancy rises to third in the world. So a lot of our healthcare problems aren't so much problems of our healthcare system, but indeed problems that are social problems. So I'm going to go ahead and give a couple of examples with regard to some cases that I think exemplify the problems of access to care. So the first one I'm going to give is a patient who presented with a myelopathy. I'll share my screen in just a minute as this pulls up. And this is a patient who's, I think he's 36 years old. He, interestingly, works in one of our local hospitals. And he worked as a, he worked in a materials management service in the OR of one of the local hospitals. He presented with a progressive cervical myelopathy and a rapid progression of gait disturbance, hyperreflexia, and he actually, by the time he presented to UCSF, he was really unable to walk. He had been recommended to have surgery at an outside facility, but unfortunately, because of COVID, he lost his job in April. And in the U.S., 50% of people's of our insured population, 50% of our insured population have their health insurances linked to their jobs. And as most of you know, during the COVID pandemic, more than 50 million Americans actually lost their work. So suddenly when you've got a healthcare system where your insurance is so closely linked to your employment, and we have a problem with employment, then indeed that leads directly to a problem with healthcare. And again, to me, that's a major problem with the U.S. healthcare system, is the fact that that becomes a very tenuous balance between health insurance and access to care. So this is somebody who recognized, and he was actually told at an outside private hospital, he was told that if he had surgery, then indeed he would be liable for the costs, and obviously that was going to be unaffordable. So I'm pulling up the case now, and I apologize for the AV difficulties. I thought that by this point of our COVID pandemic that I was actually pretty slick with Zoom, but let me see if I can pull this up. So can you see my screen again? This is a...
Yeah, we can see it, Sig.
Okay, 37-year-old, again, about 2 to 3 months of progressive numbness, difficulty walking, gait impairment, foot drop, and then this really worsened quite dramatically in a month before I saw him. In fact, he had some loss of control of his bowel and bladder function. First seen at an outside hospital, as I described. Urgent surgery was recommended, but he had lost his health insurance. So suddenly this became an unimaginable expense for him. So I saw him as an outpatient and admitted him to get, actually he came with an MRI scan, and I'm about to show you that. This is just a video. I'm not sure why I'm having these AV troubles here, but I hope I could show you. This is a video. He actually came in a wheelchair. You can see what I'm trying to show you is how hyperreflexic he is. Kind of both his legs jump. At this point, he was actually unable to walk at all. And this is part of his exam in the clinic. So hyperreflexic, 7 or 10 beats of clonus, positive Hoffman's in the upper extremities, and sustained clonus on both legs. His plain films really, this was atraumatic in onset. He said that the worsening about a month ago involved a relatively low energy fall, but really nothing remarkable on his plain films. You can see here on his MRI scan, just dramatic cervical stenosis at multiple levels, cord signal change, and both ventral and dorsal compression on his spinal cord. So again, this is somebody who presents with clearly a surgical problem. And at this point, I think it's become relative surgical urgency. Somebody with progressive myelopathy presented to me with a wheelchair. He was too spastic to walk by the time he saw me, unfortunately, and was seeing me more than a month after he was originally recommended for surgery. And again, you see the severity of the stenosis. I chose to, I mean, we could talk about what to do here, but I think more interesting is how the person got to this situation, this degree of disparity or desperateness. So the surgical solution here, I think, is relatively simple. I ended up doing a cervical laminoplasty. We could argue about going from the front versus the back, or even both. I chose to do a laminoplasty to get a wider decompression. And then this is him at his first follow-up visit. So this is actually about a month after his surgery. And I'm not sure why he's wearing his collar, but he is, you still see a bit of a wide base gait, but he's actually ambulatory now. And at the start, he wasn't able to walk at all. So this represents a pretty dramatic improvement of his health status. But the point that I think is worth talking about here is again, the notion of somebody being liable for care, so losing their insurance, and health insurance in the U.S. Being perhaps such a tenuous prospect. Again, looking at reasons for bankruptcy, the vast majority, or the largest percentage of personal bankruptcy, comes from medical issues. Again, estimated over 600,000 people a year declare bankruptcy. So more than overextending yourself in a mortgage or loans or any divorce or separation, more than any of that. And again, up to 600,000 people a year. 1 in 6 Americans actually have medical bills that they can't pay, and 1 in 12 Americans simply go without healthcare insurance. So again, and during the COVID epidemic, this increased really quite dramatically because of healthcare being associated with work. These are some numbers that suggest that under the coronavirus, our healthcare system was certainly put in under significant strain, and in the U.S. More than others. And a lot of the spending came out of pocket for a lot of our patients. Again, millions of Americans being unemployed, over 50 million in the U.S. And what this really showed was the disparities of our healthcare system. So maybe that's something that we can pause. I'll pull up another case in just a minute, but maybe I'd be interested in reflections from others in terms of whether or not you see that as a problem of our healthcare system, is people not being able to access healthcare efficiently or in a timely fashion because of health insurance.
Yeah, I mean, unfortunately, Sig, it's something I think that we all run into. And when you go to situations like that where a patient's going to be liable out of pocket, I wonder if, like choice of implant even comes into consideration. Like, for example, for that gentleman, I may have considered an anterior cervical discectomy and fusion, but my guess is that the implant associated costs from that surgery are much greater than a few laminoplasty plates. And isn't it incumbent upon us to make those types of decisions?
Yeah, it's a really important question. Certainly, again, looking at the hospital level, this is an important consideration, because at the hospital level, 50% of the direct costs of a complex spine surgery, so this isn't necessarily an ACDF, but of a complex spine surgery, 50% of that cost is incurred from the cost of implants. So absolutely, I think that there are situations where we can be, again, stewards for cost-effective care. And I think, again, being empathetic and recognizing the costs that our patients face is awfully important. Let me see if I can get through one more without a major technical glitch here. We just have a couple minutes left, right?
Yeah, a couple minutes left.
Occasionally, can you guys hear me okay?
Yeah.
Yeah, so occasionally we see that, Sig, but I think the larger issue is that, like, a lot of times we're not exposed to our patients that don't have access. You know what I mean? Like, because we don't, like, the see no evil, hear no evil. Like, we don't even know it's a problem because it never gets to our offices as a problem with access. The only times I ever see it is when friends or family or people like that are trying to get in with the doctor, and we're trying our best and it doesn't work. It reminds me of a friend of ours that just passed away that had a complication from a simple ovarian cyst removal, and she was at a very large HMO system, and
Sounds like we maybe lost Greg, Sig.
Yeah, Greg, I think where you're going with that is that that this touches us both professionally and personally in many instances. And I think in terms of being isolated from this, yeah, I think if you're in a practice that is out of network, for example, or if you're in a practice that they only accepts insured patients, and then absolutely we can be insulated from this. But again, this is where I think we've got a responsibility as stewards of spine care to try and be aware and improve access. And a lot of times, by the time we see these patients, it's because it's been neglected and it comes in as an emergency. And honestly, that's probably where I see it most commonly, is that somebody comes in as a transfer or as an emergency and something that could have been preventable. You know, Benjamin Franklin has said an ounce of prevention is worth a pound of cure. There's a lot of truth to that. But let me see if I can run through one more quickly, just because I think it's an interesting example. This is a 86-year-old with a lot of comorbidities. She's got osteoporosis, progressive deformity. Here's her x-rays. And we do a conference every Monday where we talk about the appropriateness of surgery, right? So appropriateness is a measure of risk and benefit and balancing that risk and benefit. And in this instance, I think most people would agree, an 86-year-old osteoporosis, smoking, coronary artery disease, not a great candidate for surgery. So I said at this point, I don't think I could do the surgery safely or work with some non-operative things. Having said that, oftentimes I think there's a moral hazard in spine surgery with a disassociation between risk and benefit. And one might say, hey, I've got some room in my OR schedule. Yes, like big risk of complication, but at the same time, that's no skin off my back. I still get paid for it. So one of the things that we've done is we have instituted now this preoperative optimization program where we look automatically on every patient. This is a dot phrase at blood sugar, bone health, BMI, and just walking through this. So we try to avoid doing elective spine surgery in anybody with a hemoglobin A1C more than 7, anybody who's osteoporotic, BMI more than 35, serum albumin less than 3.5, active smokers, more than 50 milliequivalents of morphine per day, patients who don't have adequate social support, patients with untreated depression, anxiety. And unless you really make a checklist out of this goes back to Atul Gawande's work with a checklist. Unless you make a checklist out of this, oftentimes you're not going to find out that somebody lives at home in a 3-story walk-up until after surgery. So working on this systematically is, I think, another way that we can avoid incurring, or that we can improve outcomes and improve costs of care, and also be good stewards for our patients. I'll just share with you, this is an email I received from one of our PAs on the floor. And what she wrote is, she said to me, she said, we had 2 transfers for this doctor. I want to make you aware that there are 2 upcoming admissions on transfer to this service. One of these patients was originally here for T4 to pelvis fusion, and it wasn't the case that I showed, but a similar case. And this person said, I expressed significant concern during our Monday morning conference about this surgery, and the surgery went ahead anyway. As you can see, this was a completely predictable complication, and I'd love to work with strategies to avoid this. So part of what we're doing to avoid this is trying to make sure that we really enforce a preoperative optimization and not bring in people with predictable complications to surgery. And again, I think that's a really important part, a method that we can do to be good stewards for our healthcare economy. We've got a preoperative optimization pathway that we designed now a couple of years ago, but we've got pathways where we can preoperatively refer people to social work, smoking cessation clinic, skeletal health for bone density optimization. We can have people seen by anesthesia, not just in preparation for surgery, but as a consultation for what do they need to be prepared for surgery. Have them seen by pain management. We actually got now a surgical wellness program where they can be seen by physical therapy preoperatively. And I think that's a really important resource for us, again, ultimately to provide patient-centered care, to be stewards for the patients that we care for. I think I might wrap it up with that case example, because I see we're at 7 o'clock, but love to hear comments from others who may have similar experience, both with healthcare disparities and with optimizing patients before surgery.
Hey, Sig, Jamie Bruffy here. I still remember schlepping our stuff for boards together, so it's been a long time. I have the role of spine care director for the system here. And one of the things I get concerned about is the disparity in care that we're providing, which is optimal, cost effective, and our ability to have our payers direct spine care to us. I mean, are you working on that with your payer systems?
Yeah, absolutely. That's actually one of the topics. There are 12 topics there to choose from, but one of them is employer-sponsored healthcare. So we specifically have been negotiating with the Northern California Business Alliance and a couple of other businesses in the Bay Area to be a preferred provider. So with Anthem, with Blue Cross, we've achieved the milestones for being preferred providers. Those have been a bit challenging. We've always met the quality metrics, but the cost metrics, UCSF has been a very expensive hospital. So we're working with our finance department to actually conscientiously carve out contracts that are more cost competitive, including some specialized bundle payment type programs. But in terms of trying to be the preferred provider, that's something that recognizing, again, 50% of people get their health insurance through their employer, and more employers are self-insured. So appealing directly to the employer simply makes sense.
Yeah, I see that too. It's just that the frustration comes with the lack of connectivity of us as individual providers and as group providers to those decision makers, and the hoops that they require in many cases seem to be disassociated with what we actually do to take care of our patients. They've got these metrics that at some point don't align with what they really want, which is a lower cost, better outcome, better outcomes with the surgeries performed reliably. And I haven't figured that out. I haven't figured out how to connect those two dots.
Well, Jamie, I'll tell you, one of the things that really made our system very attractive to some of the preferred networks that we're appealing to is that our non-operative service, we've now got we've got 6 full-time non-operative physicians at UCSF. And one of the things we've done is a PT first type program, similar to what Gordon Hamilton did in Saskatchewan, is Connor O'Neill designed a program where people see a physical therapist or non-operative provider first. And the idea of that is that the vast majority of people really don't need to see a surgeon, and surgeons are more expensive. Virtually no one on this call, and none of the attendings, I suspect, would even see a patient who doesn't already have an MRI scan or who doesn't already have advanced imaging. And we're incredibly expensive. So the idea of people being able to access a system that's less expensive. So we call this the integrated spine service. And Connor O'Neill's run a 3-year program now. And this has been very attractive to payers who really want to try and be cost-centered. And he's demonstrated that there's been significant cost savings. And the biggest area of cost saving is less imaging. The biggest area has actually been that these patients get less imaging early on.
Yeah, and that's similar to what they've done up in Mason and Seattle. I went up there, 5 years ago to look at what they were doing, and we're doing that now. We have, we've hired more non-operative care providers, and actually now have a division head we just hired to do that too. So I think we're heading in that direction. We're heading in the right direction in that regard. But for the surgical care part of it, you guys do things well. I think our guys do things well. And again, getting the connection for the surgical part of things to have patients driven away from those places that are high cost, poor outcome to centers like ours is I don't know. I'm not sure how to do that effectively. That's where I think I would go with that.
Yeah, it was certainly Virginia Mason. And Ross Shethy was a fellow with us, and he and Robert Mecklenburg have done a very good job in attracting people nationally to their center. But a big part of what that makes that center attractive, as you know, is that these are people who are getting a second opinion, who are recommended for surgery, work comp patients who probably don't need surgery. So the fact that they're saying no to surgery is a big part of what makes that attractive. Yeah, and quite honestly, that's the patient population that I'd rather not deal with in the first place.
Yeah, I agree with you. Right, I agree.
If a patient with low back pain makes it into my clinic, that's going to be a discussion with my clinic manager.
Well, looks like we're coming up against our time limit here, but Sig, we just want to thank you again for giving the talk. Obviously a very timely subject, and one that I think is important for the fellows and also for those of us who are early in our practice. So thanks again. I just want to put a plug in that all of our videos are going to be available on the online library, and we'll send a link to everyone as well. So this is part 3. Part 4 will be coming in 2 months. And then finally, I'll just end with a quote from one of the great thinkers on the West Coast, Mr. Tupac Shakur, especially for the fellows as they're getting ready to start your practice. Just make sure that you don't let the pressure get to you and positive.
Awesome. Thanks, Annie. Thanks, Sig. Awesome
Thanks,
seeing
everybody.
everybody.
Thanks for
Thank you,
have a
everyone.
great day, everybody. Thanks for spending your morning with us. Bye-bye.